Hello, my name is Yeleni Sejo de Armas. I'm a third-year internal medicine resident at Cleveland Clinic, Florida. And on behalf of my co-authors and mentor, I'll be presenting a case on an unusual cause of secondary hemophagocytic lymphohistiocytosis. Hemaphagocytic lymphohistiocytosis, or HLH, is an uncommon syndrome of excessive immune activation involving hyperactivation of CD8 plus T lymphocytes and macrophages. This leads to phagocytosis by macrophages and massive release of cytokines, resulting in high fevers, coagulopathies, and end organ damage. Multi-system organ dysfunction often leads to pancytopenia, transaminitis, hepatomegaly, splenomegaly, and encephalopathy. It usually presents in infants and young children, but it can infrequently affect adults. Primary HLH is associated with genetic mutations, while secondary HLH is associated with malignancy, infections, and autoimmune disorders. Treatment of secondary HLH usually involves treating the underlying cause. Acute lymphoblastic leukemia involves malignant transformation of precursor lymphocytes in the bone marrow, which often leak into the blood and proliferate at extramedullary sites. It has a bimodal distribution, with the first peak occurring at 5 years of age and the second peak at 50 years of age. 80% of the cases occur in children and the remaining 20% occur in adults. The case is about a 47-year-old female with history of antiphospholipid syndrome who presented to the emergency department with recurrent fevers for 9 days associated with fatigue, night sweats, and unintentional weight loss. In the ED, she was afebrile and tachycardic. Physical exam was notable for bilateral shorted cervical lymphadenopathy. CBC revealed pancytopenia. Reticulocyte count was 0.1. LDH was 694. LFTs reveal an AST of 840 and ALT of 1,845. Alkaline phosphatase was 295. Ferritin level was very elevated, above 11,000, and D-dimer was over 9,000. Ultrasound of the liver and spleen revealed no hepatomegaly and no splenomegaly. She remained afebrile for 3 days, but then she continued to spike fevers. Labs showed persistent pancytopenia, elevated LFTs, D-dimer, and ferritin levels. She was found to have a triglyceride level of 118. Soluble IL-2 receptor was elevated at 1,262. Flow cytometry revealed a normocytic anemia with occasional teardrop cells, leukopenia with left shift, and thrombocytopenia. There was no evidence of a lymphoproliferative disorder or acute leukemia at that point. Bone marrow biopsy subsequently revealed a B lymphoplastic leukemia with 83% blasts. On microscopic examination, numerous macrophages with intracytoplasmic red blood cells were observed, concerning for hemophagocytosis. Hemaphagocytic lymphohistiocytosis is a hyperinflammatory syndrome that usually occurs in infants and younger children, unlike our patient. It can occur secondary to malignancy, as evident in our case. Secondary HLH due to malignancy most commonly occurs with T or NK cell lymphoid neoplasms. Surprisingly enough, in our case, it occurs secondary to B lymphoplastic leukemia. Such association of HLH with B-ALL, in addition to the age representation in our patient, make this an unusual case. It is important to remember that although HLH is more common in infants or children, it does occur in adults, and it can be associated with B-ALL. Thank you very much.